Hi everybody, welcome to Dr. Manny's YouTube Learnshops. This session is about abdominal assessment. Now, the learning outcomes for this session are that you should be able to name the organs located within the gastrointestinal system, briefly explain the function of each of the gastrointestinal organs, rationalize the importance of a health history, describe the patient's preparation prior to the abdominal assessment, and explain the process for performing the assessment of the abdomen, and finally to state the normal and abnormal abdominal assessment findings for the specific conditions mentioned. Okay, let's review some of the external abdominal structures. You can see there very clearly. You've got the integumentary system, the skin, so you can see the abdomen and you can see the umbilicus. The umbilicus is always central. Then you've got the muscles. The abdominal muscles essentially support the trunk. They allow movement, they hold the organs in place, and they do so by regulating the internal abdominal pressure. The deep abdominal muscles, together with the muscles in the back, make up your core muscles and help keep your body stable and balanced and protect your spine. Let's review the 4 abdominal quadrants. The 4 abdominal quadrants are the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. And they're important because they give you an idea of where and what organs should be located in these quadrants. Typically, in the right upper quadrant is the liver and the associated gallbladder. In the left upper quadrant, you've got the stomach and the spleen and the pancreas. In the right lower quadrant, you've got your bowel, small and large. In the left lower quadrant, small and large. They're important because they help you identify where your organs should be located. Now let's subdivide the abdomen into 9 specific regions. And it's further subdivided to allow you to identify issues in these specific areas. The right hypochondrium, left hypochondrium, the right lumbar region, left lumbar region, the right iliac region, left iliac region, epigastric, umbilical, and hypogastrium region. Why are they important? They're important to identify where certain organs could be located and whether there's referred pain. So they're very important for identifying pain issues in the patient. The right hypochondriac, liver, gallbladder, right kidney, small intestine. Left hypochondriac region, spleen, colon, left kidney, and the pancreas. Epigastric, typically stomach, liver, pancreas, small bowel, parts of spleen. The adrenal glands. Right lumbar, gallbladder, liver, right colon. Left lumbar, descending colon, left kidney. The umbilical region, parts of the small intestine. The right iliac region, the appendix and cecum. Left iliac, descending colon, sigmoid colon. The hypogastric region, the urinary bladder, sigmoid colon, and ovaries. Let's review some of the structures located in the gastrointestinal system. You've got the oral cavity, which contains salivary glands. You've got the pharynx, joins to the esophagus, the stomach, other organs, the liver, the spleen, the pancreas, the gallbladder. You've got the small intestine, large intestine, and the rectum. When we look at the gastrointestinal system, the digestive tract essentially consists of the mouth, the pharynx, and the epiglottis. The esophagus, the stomach, small intestine, large intestine, which is the colon. The epiglottis is an upper respiratory tract structure. Take note of it. It's a leaf-shaped flap of cartilage located behind the tongue, at the top of the larynx, sometimes called the voice box. The main feature of the epiglottis is to seal off the windpipe, trachea, during eating, so food isn't accidentally inhaled. Food does not go into the respiratory tract. Only air goes into the respiratory tract. Accessory organs within the digestive tract are the teeth, the tongue, salivary glands, the liver, pancreas, and the gallbladder. What do you think are the functions of the mouth? The teeth are responsible for mechanical digestion, which basically breaks down the food when you bite and you chew. The tongue has got the responsibility of mixing the food with the saliva, and saliva contains amylase, which breaks down starches. It's the first phase of chemical digestion. Then you've got the pharynx. The pharynx transports and swallows. We already mentioned the epiglottis protects the airway. No food goes into the airway. During swallowing, the soft palate and the uvula move together, also to close off the nasopharynx and prevent food from entering the nasal cavity. We've all got salivary glands. What do you think are their function? You have the sublingual, the parotid, and the submandibular salivary glands. Well, the functions of the salivary glands are to produce saliva. And as I said, this is the first stage of chemical digestion. It starts to break down starches, lubricates food so it's easier for it to move into the stomach. And as I said, there are three pairs: the parotid, submandibular, and the sublingual. So what do you think about the esophagus? What's the esophagus? Well, the esophagus is a long, thin, muscular tube that connects the pharynx, which is the throat, to the stomach. It forms an important component of the gastrointestinal tract and functions as a conduit or a tube for food and liquids that have been swallowed into the pharynx to reach the stomach. The esophagus does have a peristaltic action, and it helps food migrate or pushed towards the stomach. So therefore, the esophagus is a muscular tube that transports food. It connects the mouth to the stomach. It's approximately 10 inches long, and there is some mechanical digestion because it uses peristalsis to push food towards the stomach. Here's a question. Can you swallow food while standing on your head? If you ever do stand on your head. And the question is, or the answer is, absolutely, yes. Because once food enters the esophagus, the peristaltic waves push it towards the stomach, regardless of the body position that you're in. What then is the function of the stomach? The stomach digests food. It's a J-shaped muscular sac with rugae or folds in it that increase the surface area. And my mechanical digestion occurs here. the stomach actually moves considerably. It squeezes, it squashes, it pushes, it mixes food into what is called chyme. Broken down food and gastric juices. This is chemical digestion. And the gastric juices contain hydrochloric acid, salts, enzymes, water, mucus, and they break down food and they do kill bacteria. The stomach has got a fundus at the top. It's got a body, the main part, and it's got an antrum, the lower part. It's got two sphincters, the cardiac sphincter or the cardia sphincter, and the pylorus or the pyloric sphincter, and this controls food going in and going out of the stomach. Both. The cardiac or the cardia sphincter prevents regurgitation back into the esophagus, and the pylorus allows broken down digested food into the small bowel. You can review the picture, but within the stomach you can see the rugae, and the rugae are just indentations or curves which provide a big surface area so food can be digested effectively. Here you can also see, as we said, produces mucus, bicarbonate, hydrochloric acid, lots of gastric enzymes, lots of mucus. Mucus is essential to be produced, otherwise you'll end up getting gastric ulcers, or ulcers in the small bowel, or esophageal ulcers. Now we move on to the small intestine. The small intestine in humans, it's about 6 meters or about 20 feet. The large intestine, about 5 feet or about 1.5 meters. So if we look at it on the information that I've given you, the length typically of the small intestine is about 21 feet or 7 meters. The duodenum, about 15 inches. Jejunum, 8 feet, 2.5 meters. Ileum, 12 feet, 4 meters. And what's its function? Its function is to continue to break down food, to digest food, such as carbohydrates, proteins, lipids. It's chemical digestion. And additional digestive juices are liberated and sent into the small bowel from the pancreas and the liver. Then you've got the large intestine. As I said, the large intestine, it's not as long as the small intestine. Oh, it's about 5 feet, 1.5 meters, something like that. It consists of the ascending colon, the transverse colon, and the descending colon. And it ends in the rectum. We'll be looking at the appendix later on. In the large colon, there's no further digestion. The primary function of the large colon is to eliminate fecal matter or unwanted waste material as a process of digestion. It has a very important role to reabsorb water. That's why if you don't empty your bowel when your body tells you to empty your bowel, it continues to absorb water, absorb water, absorb water, and your feces becomes very, very hard and you'll probably become constipated. It also produces bacteria that produce vitamin K and B, which are essential in blood clotting and to be healthy. It stores and concentrates feces. You can call it stool, but proper terminology is feces. And peristalsis moves the feces to the rectum where it's expelled. Feces is essentially indigestible fibrous material. So what do you consider the functions of the rectum then? Well, the rectum is approximately 12 centimeters or 4 inches long, and its function is basically to store feces temporarily so you can expel it. Any distension in this area gives you an urge that you want to defecate or expel the stool. And then, with the sphincter released, feces is evacuated. The anal sphincter. Now we need to review what feces or stool is. Yeah, we do. I don't want to, but we do. Feces. What's feces? Well, feces is the medical term for your stool, and it's proper terminology. Now, if you've got brown feces, because as clinicians in the clinical area, you're going to have to be observing for this. Brown feces means typically that it's okay, because feces is naturally brown as a consequence of the bile that's released into the bowel from the liver. So it's not brown, it's potentially problematic. Feces or stools is indigestible material, which means it's undigested, and its colour is brown, normally. When it's green, that's abnormal. But food might be moving through your bowel very, very quickly, diarrhea, and as a consequence of that, it hasn't had an opportunity to change as quickly. Because if you've ever seen bowel, and you will when you go to surgical wards, the bowel is essentially greenish. It's not brown. It only turns brown after it's been digested. Or you might be a very health conscious person and you could have eaten lots of green leafy vegetables, or maybe you've eaten something that has got food colouring in it that it's green. Then you've got light coloured, white or clay coloured. Now this is not normal. This would be a concern. And it could mean, doesn't mean it does mean, it could mean that you've got a biliary tract obstruction, because bile can't get into the small bowel, therefore it can't get into the large bowel, and that could be problematic. However, you could also be on medications which could cause similar situation. This requires medical intervention or advice. If it's yellow, it's problematic, because typically it doesn't smell very nice, it's very greasy, and this indicates probably that you've got a lot of fat in your stool. And this could be related to a disease order, something like celiac disease, where you have malabsorption. But it can relate to other things as well. Then you've got blood stained or red, and you better be worried. If you see this, you need to alert the physician that your patient or yourself has got a problem. And typically blood in the stool could be a symptom of carcinoma. So you should always see a doctor if you find blood in your stool. Bright blood in your stool typically means it's at the lower end. It could be related to hemorrhoids. It could be related to some form of injury. It could be related to cancer. Melena, or very dark, foul-smelling blood-stained stool, could indicate that you've got a problem higher up. It could be related maybe to gastric ulcer, a duodenal ulcer, cancer. Again, it requires medical advice and investigation. Then you've got black. This is the one. Black as well is potentially problematic. Doesn't mean it will be, but it could be. This could be melena, which means digested blood. From bleeding higher up, gastric ulcer, duodenal ulcer, small bowel ulcer. It could mean that vitamins containing iron can cause black stools. But melena is typically very, very stinky, foul smelling, and it should be seen or investigated by a physician, a medical doctor, because it could mean cancer as well. This is a tool, and there are many tools to evaluate feces in their formation and their colour. This is just one that I've chosen at random. It seemed okay. And the Bristol stool form scale talks about 7 types of feces, ranging from 1, severe constipation, to 7, severe diarrhea. And as you migrate or navigate from form 1 to form 7, it becomes less consistent. It becomes greater in fluid consistency, because from 1 to 7, the stool moves much faster through the bowel. Diarrhea typically is more frequent stool, so it's watery. It's more liquefied. Type 1, it's slower, so it's harder. This indicates severe constipation. So type 1, severe constipation. Type 2, mild constipation. Type 3, normal. 4, normal. 5, lacking fibre, more fluid. 6, mild diarrhea. 7, severe diarrhea. The Bristol stool form scale. Now let's move on to some of the accessory organs. What are the functions of the liver? Well, the liver is an organ that synthesizes or produces coagulants and anticoagulants. It's responsible for thrombolysis, fibrinolysis, and coagulation, thrombus formation. It produces bile, amino acids, proteins, and urea. It processes cholesterol. It gets rid of LDL via HDL. LDL is low density lipoprotein. HDL is high density lipoproteins. It makes sure that you don't have too much cholesterol. However, if you don't have enough cholesterol, which you need, cholesterol is actually a building block of the body. It will produce the cholesterol if you're deficient. It detoxifies or filters the blood. It stores glycogen, also blood, iron, vitamins A, D, B12 and K. It has more functions than those, but they're the main functions. The liver, as we indicated earlier, is typically located in the right upper quadrant of the 4 quadrants of the abdomen. As I said, it's got a lot more functions. I've just mentioned a few. If you're interested, you look them up. Then we've got the gallbladder, which is typically located posterior to the liver, also in the right upper quadrant. What are the functions of the gallbladder? Well, the gallbladder concentrates and stores bile, and then when required it secretes it into the duodenum to break down fat. Okay, let's review the pancreas now as an accessory organ in the gastrointestinal system. What is it? Well, it's an exocrine and an endocrine organ. As an exocrine organ, it has a cini and it secretes pancreatic juices. And the pancreatic juices aid breakdown of food and prevent damage from hydrochloric acid that comes with that food. So they secrete bicarbonate, lipase, amylase, and proteinases. As an endocrine organ, the islets of Langerhans have alpha cells, beta cells, and delta cells. The alpha cells, or the A cells, secrete the hormone glucagon. The beta cells, or B cells, produce insulin and are most abundant of all the islet cells. The delta cells, the D cells, secrete the hormone somatostatin, and this is also produced by another of other endocrine cells in the body. In the pancreas, however, somatostatin inhibits the secretion of pancreatic hormones such as glucagon and insulin. So let's briefly review. The mouth breaks up food. It also allows you to speak. The salivary glands moisten and lubricate food. Amylase, which is produced in the saliva, digests food first, polysaccharides. The pharynx allows you to swallow. The esophagus transports the food. The stomach stores and churns the food, also aids breakdown with pepsin, hydrochloric acid, other enzymes, and kills germs. It also produces a lot of mucus to line the stomach and protect it. Then you've got the liver. The liver helps in the breakdown of food as well. It stores lots of vitamins, destroys old blood cells, destroys toxins. Bile aids in digestion. The gallbladder stores and concentrates the bile. Then you've got the pancreas. And the pancreatic hormones regulate blood glucose, provides bicarbonates to neutralize the stomach acid, also allows trypsin and other variants of trypsin to digest proteins. Amylase digests polysaccharides, lipase digests lipids or fats. The small intestine completes the digestion, and mucus protects the gut wall, because again it's also at risk of hydrochloric acid from the stomach, and breaks down a variety of other elements such as proteins, sugars, polysaccharides. The large intestine's primary function is to reabsorb water and forms and stores feces. The rectum stores and expels feces. The anus opens for elimination of the feces. You can look at that. Oh well, primarily the GI tract, propulsion, chemical digestion, mechanical digestion, and absorption. Now let's move on to a health assessment. The first component is the health history, which consists of the chief complaint, the present problem, the past medical treatment, past surgical treatment, the family history, and the social history. The chief complaint is what brought the person into hospital. This is a medical term used to describe the primary problem of the patient that got them to come and seek medical help. And in our session, we're talking about abdominal pain is often a chief complaint. This woman has abdominal pain. A tool that we can use to assess pain is called S.O.C.R.A.T.E.S. There are many, many others, but this is the one that is being recommended in this program. So S.O.C.R.A.T.E.S consists of S, the site, where's the pain? Onset, when did the pain begin? C, character, is it sharp, dull, or is there an ache? R, radiation, does it go anywhere? A, are there any associated symptoms, like for example, nausea, vomiting? What's the timing? When did the pain actually begin? E, exacerbating or relieving factors. Does anything make it better or does anything make it worse? S, severity. How bad is it on a numerical scale of 0 to 10? 0 being no pain, 10 being incredibly bad. The worst pain that you've ever experienced. S.O.C.R.A.T.E.S as a pain assessment tool. The present problem refers to differential diagnosis. I mean, if you've got abdominal pain, it could be coming from any of the 4 quadrants or any of the 9 regions which we looked at earlier. So we have the right upper quadrant, the left upper quadrant, the right lower quadrant, and the left lower quadrant. And this could imply all these problems. The epigastric region, for example, could be associated with even myocardial infarction as a result of referred pain. The heart sits on the diaphragm, which migrates into the epigastric region. You can have the periumbilical region, which is primarily related to bowel. However, the abdominal aorta could be an issue in this area as well, which we'll review as we go through. Okay, what are some of the types of abdominal pain? Well, you've got visceral pain, which basically means from an organ. And typically it's vague, diffuse, hard to locate, hard to be specific, but typically it's located midline. And it may be accompanied by nausea. And it may be related to an ulcer, whether it's a gastric, sometimes called peptic, duodenal, also sometimes called peptic ulcer. Then you've got parietal pain, which is from the deeper regions in the peritoneum, and it's more intense and localized, and usually to a side, usually the right upper quadrant, or the right lumbar region, or the right iliac region. And this could be related to your appendix being inflamed. Charles McBurney, he's an important character, or physician actually, and McBurney's sign is something that you may utilise to determine whether there's an appendix problem, appendicitis. We'll be discussing this later on. Then you've got referred pain, and referred pain just basically means it's coming from somewhere else. And it typically isn't coming from the area where the problem is located. So for example, with the gallbladder, typically you can get back pain. It can be low, it can be high. It may be located between the scapula. And it's visceral pain or organ pain, and it gets worse. It could be because of an inflamed gallbladder, which has become obstructed because of cholesterol. Gallstones. Gallstones are pure cholesterol. And it's typically related to transmitted pain from other things along nerves. So for example, you can have abdominal pain which is referred to the tip of the shoulder, because typically it's located beneath the diaphragm, and the diaphragm holds the liver, the spleen, the pancreas, the gallbladder, etc. And this referred pain to the tip of the shoulder is referred to as Kerr's sign. And it could indicate that you've got a gallbladder problem. But it could be related to any of the abdominal organs located below the diaphragm. Yeah, here's just a diagram that can show you where referred pain is. Have a look. What can we choose? Okay, the heart. The heart, typically, when someone has got a cardiac problem, ischemic heart disease, pending myocardial infarction, they can get left shoulder pain or ache. It can travel along the left arm to the tips of the fingers. You may not even be able to lift the arm. It may seem like you're having a stroke. Or you can get pins and needles or tingling in the fingers. You can get an ache. And this is related to the nerves associated with the arm and the heart. Or you can get, let's have a look, appendicitis. Well, there's your appendicitis. And appendicitis can have referred pain that goes down into the iliac region, right iliac region. These are all types of referred pain. Look at the lung and the diaphragm. Yeah, interesting. Look at the lung and the diaphragm up in the neck. Well, I mean, the diaphragm, as I said, is associated with the pancreas, the gallbladder, the liver, the spleen, and this can refer pain up into the neck, which you would never typically associate with the pancreas, pancreatitis, gallbladder, cholecystitis, referred pain. The important thing is that you identify that they have abdominal pain, and then they refer to a physician, and they'll probably have an abdominal X-ray, abdominal CT, abdominal MRI, it depends. Then you've got the past medical or surgical history, and that becomes important because alcohol abuse, gastritis, gastric ulcer, menstrual cramps, ectopic pregnancies, constipation, urinary tract infections, gallstones, intestinal obstruction, irritable bowel syndrome, or previous abdominal surgery, which can result in lots of adhesions. Any form of surgery will cause healing, inflammation, and this could cause adhesions. This could cause abdominal pain. Let's review this. It can't be a class activity, but I left it in situ because it's a case study. This is Madam Rahani. She's 56 years old, divorced, a mother of 2 grown children who came to the clinic for her annual checkup. She works in a local factory and states, "Look, I'm constipated all the time." She's got a family history of colon cancer, and considering her brief complaint and the fact that she's not had a complete physical checkup for several years, a complete health history and physical examination are absolutely necessary. And you may be the one taking it or doing it. The targeted abdominal history focuses on her complaint. It could include, does she have pain, dysphagia, dyspepsia? Has there been a change in her weight? Is she nauseated? Is she vomited? Does she vomit blood? Has she had a change in her appetite? Is she able to eat foods or not eat certain foods that she could before? Are there a change in her bowel habits or her urinary habits? Think about frequency, colour, consistency. Does she use stool softeners so it's easier for her to empty her bowel? Is there any evidence of blood in her stools? Is there a family history of smoking, alcohol? What's their occupation? Does she exercise? Is there a past medical surgical history with gastrointestinal problems? Has she had surgery? Is she allergic to anything? Does she use over-the-counter medications? These are all components of a targeted abdominal health history. Absolutely, as we said, S.O.C.R.A.T.E.S can be used to assess any issues related to pain. But it's important for you to remember, you don't volunteer any information. You don't answer her choices. So for example, you don't say, is the pain sharp, dull, is it ache? She answers those questions. You don't prompt. You just say, can you tell me about the type of pain you're experiencing? Does it go anywhere? What's the timing? Meaning that how long have you had it? Is it acute? Is it chronic? Is it sudden? Is it old? Meaning, have you had it for years, months, weeks, days, hours, minutes, seconds? You only ask the question. You don't answer. Okay, now let's review some of the essential landmarks which we've already reviewed when we looked at the 4 quadrants and the 9 regions of the abdomen. Some of the landmarks that are important for you to remember: the xiphoid process, right down to the pubic crest. The umbilicus. The xiphoid process is an idea of where the diaphragm separates the thorax from the abdomen. The pubic crest, you're in the pelvis. The umbilicus should be midline. The 4 quadrants we've already reviewed. Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. Because this will help you locate or identify where organs should be located. The 9 regions, again, essential to possibly identify where there are pain issues and to have an idea of what organs are typically located in these regions. To be more specific, especially with identifying pain. Then we're going to do an abdominal assessment. And preparation is essential. You want the patient to be calm and relaxed, otherwise you're not going to get the information that you want. So the environment should be very private. It should be warm, the lighting should be ambient, not too bright, not too dark. And you as the nurse practitioner, please be caring, please be confident. Remember your role. You're not a doctor, you're a nurse. And when it comes to physical assessment, from my perspective, doctor has a role, the nurse has a role, as I'll point out as we go through. But the most important thing, care about what you do and be confident, even if you're not confident, even if you're nervous, because the patient will see that. The patient will feel that. The patient should be comfortable. Make sure the bladder's been emptied, unless of course you're assessing bladder function for various reasons. You don't want the patient squirming around because it's uncomfortable. Possibly you want the patient to be pain-free. Positioning of the patient should be supine. Pillows should be under the head and the knees. And painful areas, chief complaint, should be examined first or maybe last. It depends on what sort of pain. If it's severe pain, then you want to determine what the problem is. Because if they've got severe abdominal pain in the right upper quadrant, which could indicate appendicitis, or in the right lower quadrant, which could also indicate appendicitis, or in the umbilical region, which could also indicate appendicitis, you want to make sure that a doctor sees the patient ASAP, as soon as possible, because this appendix could be impending to rupture, or it could already have ruptured, which will result in peritonitis, septic shock, and the patient could die. When it comes to abdominal assessment, the method, there are standard precautions. Hand hygiene, personal protective equipment if required. You need the patient's consent. Ask the patient. Introduce yourself. Hi, I'm Dr. Manny. Do you mind if I do a physical assessment on your abdomen, on your tummy? Permission is required. This is a form of verbal consent. The nurse then explains the examination process. She or he speaks slowly and clearly during the examination in the appropriate language for that patient. You stand on the right side of the patient. Depends on you, your comfort zone. Or you stand on the left side, but typically it's on the right side because most people are right-handed. You observe for signs of discomfort or pain during the assessment, and you use the 4 assessment techniques, which are, for an abdominal assessment, inspection first, auscultation second, palpation and percussion, or percussion and palpation third and fourth. When you watch the video for the OSCE examination, they don't do it in that sequence. But the reason that you do auscultation second is because you don't want to disturb the abdomen with palpation and percussion, or percussion and palpation, because this could increase or decrease the abdominal bowel sounds. But it's your preference. You try and visualize the abdominal organs under the 4 quadrants. That's your objective. That this is probably normal. That this is not normal. That this is not normal, but it could be normal. It could be someone who's got S.O.C.R.A.T.E related to having been obese, or being pregnant, or having a distended abdomen for other reasons, and the skin has overstretched and been permanently damaged. This is not normal, but it's normal. S.O.C.R.A.T.E. Once we know the history, we're not as concerned. This is not normal. This is definitely not normal. This is not normal either. This is called Cullen's sign, and it's typically related to bleeding intra-abdominally. We'll discuss that as we go through. Here, this is your ecchymosis, where you've got the breakdown of blood, which comes forward into the tissues. You may have on inspection visible pulsations. Now, sometimes you can see pulsations if the person is really thin. But most of the time, visible pulsations are abnormal, and it can be related to an abdominal aortic aneurysm. It can be related to portal hypertension, related to liver cirrhosis. It can be an intestinal obstruction where you can see peristaltic movements or pulsations. An AAA is an abdominal aortic aneurysm. Here, this could be related to something like interception, where the bowel is obstructed. Here, you can see visible peristaltic movements. You can see the bowel, probably related to an obstruction. You've got abnormalities such as ascites, very distended abdomen. And all you're doing is inspecting. Then you've got Cushing's syndrome, which can result in certain S.O.C.R.A.T.E. Cullen's sign, peritoneal bleeding. Gray Turner's sign, intra-abdominal bleeding. You can see hernias. They can be umbilical before, if you get the person to perform a Valsalva manoeuvre, which basically means increasing intrathoracic and intra-abdominal pressure, sometimes it can bulge out. But this is visible, and you can see that it's abnormal. I would recommend auscultation, as most of the experts do, and it's typically performed second in an abdominal assessment. And the reason is because you don't want to make the abdomen excessively active or quiet, which can sometimes happen if you're doing percussion or you're doing palpation. So typically, I'm recommending that you do it second for those reasons. However, when you watch the video that is also associated with this presentation, or your practicum, they do it last. And that's typically not recommended. Auscultation is listening with a stethoscope to sounds. And you can listen to heart sounds, lung sounds. We're listening to bowel sounds. You can also listen to blood vessel sounds, which are abnormal, and they're called bruits. The tools that we need for auscultation are the stethoscope, or the bell, or the diaphragm. And look, your ears as well. There's your stethoscope. The bell is the small concave disc at the end of the stethoscope. The diaphragm is the flat. Okay, when we do abdominal assessment for bowel sounds, we use the diaphragm. And the diaphragm is for high frequency sounds. And high frequency sounds are typically hyperactive. The bell is for low frequency sounds, like hypoactive bowel sounds. However, when you listen with the diaphragm, you listen over all 4 quadrants. And you should listen for at least 2 to 5 minutes. But no one is, because 2 to 5 minutes, 5 minutes, 4 quadrants, that's 20 minutes, 2 minutes, each quadrant, that's about 8 minutes. However, it's acceptable to listen for about 10 to 20 seconds over each quadrant. However, if you don't hear any bowel sounds, you've got to listen for at least 2 to 5 minutes before you can say they're absent. Now, bowel sounds are normally high-pitched, and they consist of clicks and gurgles, and they occur about 5 to 30 per minute. They're irregular, and they occur at a frequency of around about 15 to 20 seconds, irregularly. Hyperactive bowel sounds, or borobogamy, they occur more often than 30 per minute. And they're loud, they're growling. And typically, you hear them yourself, or you feel them yourself when you're hungry. In an abnormal situation, it's typically because it's related to an impending bowel obstruction. When they're hypoactive, you've got less than 5 per minute. And this is normal after surgery, abdominal surgery, because the bowel is handled, which it doesn't like doing, and it goes into a paralyzed state, which recovers typically after about 24 hours. In the abnormal situation, it's normally related to a paralytic ileus. Listen in all 4 quadrants: right upper, right lower, left lower quadrant. Then you've got vascular sounds, abnormal vascular sounds. Vascular sounds on an abdominal assessment typically uses the bell or the diaphragm, it's up to you. And you listen over 7 landmarks for at least 5 seconds. And if you hear something, this is probably going to be called a bruit. And a bruit is a vascular murmur. It's a whooshing sound. And it's created by turbulent blood flow in an artery, which means the artery is partially obstructed and it's localized at that area of the obstructed artery. If you feel it during palpation, this is called a thrill. So you listen over 7 major arteries in the abdomen: the aorta, the renal arteries, the iliac arteries, and the femoral arteries. Here you can see the locations with the organs exposed. Then you've got friction rubs. Friction rubs are low frequency. So you use the bell. The bell makes it louder. And you listen over each landmark indicated in the diagram. A friction rub is typically rare. It's related to inflammation, an inflamed peritoneum. It's an abnormal sound, and it sounds like rubbing or grating. It's a creaking sound, like rubbing leather together, and it's a continuous sound. And it can be referred to as a murmur, but it's a rub. It's a friction rub. The important thing is you hear something abnormal in the abdomen and you escalate it to the doctor or the physician or your senior. And a friction rub is generated by roughened peritoneal surfaces, which are typically related to the liver and the spleen. Inflammation. Have a look. This is where you could listen. Splenic and hepatic friction rubs. Friction rubs may be painful as well, so you can use your 9 regions to identify which organ it could involve. Then you've got what is called a venous hum, and these are pretty rare. Sometimes you may hear them in pregnancy. But the presence of an abdominal venous hum is virtually diagnostic if it's abnormal of portal vein hypertension, which statistically is secondary to cirrhosis of the liver. If a venous hum radiates or is confined to the chest, it could be mistaken for a cardiac murmur. But in this situation, you listen over the epigastric or umbilical region, and if you hear a hum or something different or a whooshing sound, this is abnormal. And it can be generated by turbulent blood flow as well in the portal and venous systems. And typically it's diagnostic of portal vein hypertension, which is associated with liver cirrhosis. Look at your quadrants. You're looking at the epigastric region or the umbilical region. Just look at the umbilicus. Or divide the abdomen into your 9 regions, and then you've got your epigastric region. Venous hum can be related, as I said, to portal hypertension. You've got superficial veins there. That's called capitis medusa, which we'll look at as we go through. This is related to liver cirrhosis and portal hypertension. Then you've got palpation. Palpation is typically performed 3rd or 4th. I've put it 3rd here. And palpation just means touching and watching for responses. Your tools are your finger pads, your fingertips, your forefinger, the ball of your hand, the back of your hand, the whole hand. It depends on what you want to find out. So for example here, when you're palpating a radial pulse for rate and rhythm, you'll be using your finger pads. When you're feeling a carotid pulse, your finger pads. When you're assessing temperature, the backs of your hand, because they're more sensitive than the palms. The palms you use all the time. The backs of your hands or fingers you don't. Here, you're using your whole hand to determine grip. Maybe you're suspecting stroke or muscle weakness. Palpation can be light or deep. Light uses the fingers only to a depth of about 1 to 2 centimeters, and the rationale is to determine texture, temperature, moisture, pulsations, tenderness, vibrations, thrills or masses. Deep uses the hands. It can be bimanual as well, using 2 hands. The depth is typically 4 to 5 centimeters, and the rationale is to determine the size, the texture of the organ. And this typically means the liver, the spleen or the bowel. When you look at the video presentation, that's a little bit more involved, which you won't be expected to do. That's a medical student, they have to know a little bit more. Deep palpation. When you're assessing the abdomen for ascites, you've got a distended abdomen, and you'll recognise that it's distended. But ascites means that you've got fluid, and if you've got fluid, that's abnormal. And there are numerous causes which you can read in the diagram. There's your abdominal assessment, and you've got dullness and you've got tympany. Causes could be anything from tuberculosis through to cardiac problems. There's your ascites. When you've got ascites, typically here, you've got a lot of fluid. 500 mils will give you clinical signs. 1500 mils will have this sort of picture, distension severe. When you do a clinical assessment for ascites, you're looking for inspection, the distended abdomen, the everted umbilicus or convex, full flanks, which means you've probably got about 1500 mils of fluid. You may have dilated superficial abdominal veins. You may even have striae, stretch marks, as a consequence of stim damage. On palpation, there's a fluid wave, which is called the fluid thrill test. On percussion, there may be dullness, which we'll look at shortly. Here the fluid moves. Because it's free in the abdomen. When you do a fluid wave test for ascites, you need an assistant. And the assistant places the ulnar surface of their hand firmly in the midline of the patient. You tap from one side to feel a wave on the other side. You'll feel the fluid move. The assistant placing their ulnar surface of the hand just stabilises the abdomen. And if you feel it, there's ascites present. Then you've got percussion. Percussion, you can have indirect or direct. We're only going to be discussing indirect because that's the more common one. And you may not even be expected to do it, because most of these percussion assessments are done by physicians. But indirect percussion uses the fingers and the back of the hand, which is very clear in your practicum video. The rationale is to touch and make sounds with your hands and listen to the sounds. The sounds that are typically created are tympanic. They sound like a drum. And this is typically related to gas in the bowel. Then you've got resonance, which is hollow as well, an empty stomach. Then you've got hyperresonance, which is a lot of gas in the bowel. Then you've got dull, which is a solid sound, which is impacted, possibly feces in the bowel because of constipation. Or it can be a flat sound, which is very solid. And this is typically related to masses. and these are typically performed by a doctor, and the reason is because if there's a problem in the bowel and you're too aggressive with your percussion, you could cause damage. So the sounds that are created by percussion are tympanic, they sound like a drum, they're hollow. Resonance, they're hollow as well. Hyperresonance, very hollow or echoey. Dull, solid, impacted feces. Flat, very solid. It could be a mass. When it becomes to percussion, there's a sequence that you might use. This is just one example. But as long as you percuss in all 4 quadrants, then you cover the whole area. And the primary purpose is to discover tympany or dullness. Tympany means hollow, air, stomach, bowel. If the stomach's empty and the bowel's empty, it'll be hollow. Dullness means the density of an organ. The liver is typically dense. There's tissue and blood. Stomach, if it's dull, there's food in there. Bowel, if it's dull, there's feces in there. Again, it's typically performed by a doctor because there could be issues that could relate to rupture of whatever the organ is. You can use whatever sequence as long as you cover the 4 quadrants. But typically it won't be the responsibility for a nurse, not a nurse in Malaysia. If you're a clinical specialist, you may be required to do it, but it depends on the country and the expectations and your permissions, your authority. Liver percussion is done to determine the size. Now normally the liver is about 6 to 12 centimetres at the mid-clavicular line. So for example, if you were assessing the liver, you would start at the right mid-clavicular line. Have a look, there it is on the right. There's the mid-clavicle line. And you'd start at the mid-clavicular line and you'd go until you determined lung resonance. The lungs are normally full of air, so you have tympany. So you percuss down till the sound becomes dull. Very clear in the video that you'll be observing. So for example there, 1, you start at the lung. You start percussing down, you'll hear a hollow sound. As you percuss down, hollow sound, 2. As you percuss down, you'll hear solid sound, that's the liver, and then you'll enter the abdomen again, low bowel, hollow sound. So you percuss up or down in the mid-clavicular line with the umbilicus, and you note where the sound changes. And you measure these 2 points. Or you can start at the mid-sternal line, 4 to 8 centimetres. The sound between 2 and 4 is measured and it should fall within a certain normal range. Here's just an example. Normally the stomach has got air in it. Air is in the enlarged bowel. There's air in the stomach again, tympany. You've got air in the abdomen, tympany. You've got air in the stomach, tympany. You've got air in the bowel, tympany. Other specialised forms of abdominal assessment, it's important to determine your role and the doctor's role. Abdominal assessment for masses really is a doctor's role. Because if you do abdominal assessment, palpation and percussion, that could cause trauma. So your role is to inspect, and what you'll do is you'll identify distension or swelling, And this could be hematoma, tumour, hernias, abscesses, an aneurysm, cysts, perforation. Your role is to document and inform the doctor. If you start palpating where there's an abdominal aneurysm, it could rupture. And if it ruptures, the patient could die. Palpation of intra-abdominal muscles. The patient lies supine, knees up. If there's a superficial mass, palpation of the mass is typically done by the doctor, not by the nurse. Inspection for masses. Your role is to inspect. Palpation is performed by the doctor for the same reasons that I said. Your role is to identify the distension, which could be a hematoma, which could be a hematoma or a tumour. It could be a hernia or an abscess. It could be an aneurysm, a cyst. There could be perforation. Your role is to identify, document and inform the doctor. You can have hernias that are hiatal, diaphragmatic, umbilical, inguinal. They could be strangulated. The last thing that you want to do is cause a perforation. There's an abdominal herniation. Remember what a hernia is. A hernia is protruding bowel. If it twists, this could cause ischemia, necrosis, and as a consequence of that, severe pain and rupture. These are different types of masses. Could be just fatty tissue. It could be a trapped intestine. It could be already strangulated, ischemic, and potentially necrotic. Abdominal aortic aneurysms. There's a risk. With palpation, it could rupture. That's why it's left to the doctor. When you do liver assessment, you can use also the bimanual method. And in the bimanual method, the left hand is under the patient's right flank, which is approximately the 11th and 12th rib, and you press upwards. You'll see that demonstrated in the video. The right hand is placed at the level of the dullness, and the patient takes a deep breath. Typically the doctor pushes in deeply, and you note the size and the shape, the consistency of masses. It's performed typically by doctors, so don't get distressed. This requires expert intervention. The liver is identified, and the size and the shape is noted. There's something called the palpation hook method, again performed by the doctor. This is an alternative method for palpating the liver, and it uses a hooking technique. The doctor typically stands at the patient's shoulder and faces the patient's feet. The fingers are hooked over the costal margins. The patient is asked to take a deep breath, and as a consequence of that, it pushes the liver down, and the doctor can feel the edge of the liver. The liver bumps into the fingertips during inhalation. The palpation hook method. Then you've got assessment of the abdominal aorta. And this is to assess the width of the aorta by placing your hands on each side of the aorta, which is just above the umbilicus. And this is to assess an abdominal aortic aneurysm. A width of greater than 4 centimeters with lateral pulsations is diagnostic. It's performed by the doctor because there's a potential for rupture. In other countries, It's performed by nurse specialists that are trained and experienced to assist the doctor. It's potentially dangerous because the aortic aneurysm could rupture. Then you've got appendicitis. What are the clinical signs and symptoms of appendicitis? Loss of appetite, nausea, vomiting, feeling bloated, could be diarrhea and constipation, pain in the right side of the abdomen, right lower quadrant, right upper quadrant, pain in the rectum, referred pain. They could have a fever because of inflammation. There could be flatulence or gas being passed. Remember your 4 quadrants, right upper, right lower quadrant in particular, even the umbilical region. Appendicitis means that the appendix is obstructed and inflamed and potentially could rupture. There are 2 signs that I'm going to speak about. This is called Rovsing's sign. And this is where there's a continuous deep palpation which starts from the left iliac fossa upwards in an anti-clockwise movement along the colon. And this may cause pain in the right iliac fossa because you're pushing the bowel contents towards the ileocecal valve or the appendix. And the increasing pressure is felt in the right or right lower upper quadrants. This is called Rovsing's sign, and it's typically performed by the doctor because you don't want to cause rupture of the appendix. There it is there, pressing in the left iliac fossa, and it generates pressure in the right iliac fossa. Rovsing's sign. Palpate in the left lower quadrant. It causes pain in the right lower quadrant. This is suggestive of acute appendicitis. Rovsing's sign. McBurney's sign is also another point which could indicate appendicitis. And this is local tenderness which is experienced. Have a look, umbilicus and the anterior iliac crest. The anterior iliac crest 3, the umbilicus 2, McBurney's point in between 1. And this is localized tenderness which indicates that the patient could have appendicitis. So in summary, when assessing the abdomen or any body system, always consider the underlying structures. Remember that inspection is 70% of your physical assessment. What you hear, see, smell is what you know. If you don't know anything, you won't see, hear or smell anything. Palpation, percussion and auscultation all require practice. And in the clinical area is where you practice, but you've got to get permission from the patient. Okay, thanks again. And if you found this of any value, come and have a look at some of the other Dr. Manny Learnshops on YouTube. Bye for now.